Good afternoon, everyone. Thank you for joining us today for our ICTR Enrichment Series presentation. Today's presentation has two parts, so I'd like to welcome Dr. Fadia Shaya in presenting Data to Action Research, a precision approach to population health. Dr. Shaya is a professor and executive director, behavioral health research team, data and implementation science, data action. And she's the director of the Center on Drugs and Public Policy at the University of Maryland School of Pharmacy. She's also our co-director for our ICTR Informatics Core here at the University of Maryland, Baltimore. Our second speaker is Avery Johnson. Avery is also from the School of Pharmacy here at the University of Maryland. She's the Director of Pharmaceutical Research Computing, Data Analytics, and her topic is real-world data resources available to UMB investigators, ICTR support, PHSR datasets, and PRC core services. Dr. Fadia Shaya, unfortunately, is not here today, so she has graciously recorded her session for us. So that's what we will be sharing with you today. And then Avery will follow with her presentation. At the end, we will have an opportunity for a chat session. If you have any questions, you're more than welcome to add them in the QA session or just add them into the chat box and we can go through those. Also, we will have a survey, a satisfaction survey link that will pop up on your screen when you exit out of the meeting. We would appreciate if you would take a few moments to fill that out. And with that, let me get started with Dr. Fadia Shaya's presentation.
Hello, I am delighted to be presenting to you today. Thank you very much for hosting me. And it is a great collaboration with PRC, Avery, and Avery that I want to thank. With this, I would like to get started and talk today to you about data to action research, adopting a precision approach to population health. And I would like to start logically with the Olympics. But really, this is about what is happening currently in front of our very eyes, which is the demonstration of the success of teamwork. And I want to say that nothing will be possible here without the teamwork under the leadership of Dr. Davis and the ICTR. And the faces that you see here are only a sample of all the people who are participating in these initiatives of translational research on our campus in collaboration with others, with Hopkins and other collaborators and colleagues. We cannot do it alone, and that's really the name of the game going forward. With this, I would like to start and recognize that we are sitting on a treasure trove of data right now for any work in translational science. The compound annual growth rate of data through 2025 exceeds the rate of growth in all the other industries that might be more visible to the general public, including only 25% for media and entertainment, whereas with healthcare data, we are at 36% and growing. Healthcare data always has to be considered in the context of human health, of course, evolving in the context of those concentric circles, interpersonal settings and policies. And all the impact that we can have has to follow that spectrum. For the time that I have with you today, I would like to present to you two cases, one focused on a drug exposure study that we have been able to complete in the context of our ATIP ICTR-funded grant, and the other one that is more population-based and focused on COVID-19 prevalence and mortality. With this, I would like to also tell you that we will be happy within the ICTR and as researchers in general, of course, to have discussions about your own research how to make sure that you are working with the variables that you need, the data that you need, and also helping you in the continuum and the spectrum of your research. So let me start with case number 1, an exposure study based on opioid risk reduction. The context here and our aims were, number 1, to develop a risk score for opioid addiction that for patients that are unexposed and inform prescribing behaviors. And second, predict the risk of overdose and preempt an overdose event. What are the methods that we use? And I'm using these so that you can use them, you can see them as examples of what you can apply in your own research. The preliminary descriptive analysis was performed to evaluate the distribution, mean frequencies. This is more of the exploration of the data. First of all, I would say about 80% of our time is spent understanding our data. And then we apply the analyses and the methods that we had set out, in this case, multivariate logistic regression, to evaluate the association between socio-demographic characteristics, comorbidities, and our outcomes of interest. In this case, we also use machine learning algorithms using support vector machine and random forest to perform feature selection in order to identify the high impact parameters in the data. And then we calculated the scores. Let's see here how what the data or what the results would look like. In our data set, which we use the IQVIA PharMetrics Plus, covering this time period through 2015, we had over 1 trillion total observations. And this is the beauty of accumulated data, is that you can have very large numbers of either exposures, or even when you look at it at the unique patient IDs, we had a total number of individuals of just under 1 million, corresponding to that over 1 trillion total observations of claims data. Within these, we had a total number of individuals who were identified as having an opioid use disorder of just under 67,000, and those with an overdose were about 6,000. So who were these patients or people in the data set? The age distribution was mostly aged people over the age of 55. And remember, this is commercial populations. So this is not Medicare, and it's not Medicaid either. It's not institutionalized. We do not have nursing home data there. It's people dwelling in the community who have commercial insurance. And the distribution was 2/3 female. The other question we ask is, that's relevant also to our question, is what type of insurance would they have? We said mostly commercial, about 43%. We had some that were self-insured, about 20%, and the rest were distributed across different sections because they were probably dually enrolled. And with respect to how they were distributed across the nation, was about equally across the 4 regions of East, South, West, and North. In the clinical setting, which is also an important question to ask, is what type of provider type that they have. And most of them were enrolled in PPOs, preferred provider organizations. Some of them had no enrollment at all, and some of them had some indemnity and traditional provider services. The day's supply of opioids was a very interesting topic for us because of the CDC guidelines on the length of exposure that is plausibly or potentially clinically related to higher risk. And we saw that in our data sets, interestingly, the majority, 64% about, had only between, up to 3 days of a day's supply, indicating potentially acute indications. The remainder next was between 1 month and 2 months of day's supply. Slightly high, certainly higher than indicated, but indicating or pointing to a higher risk, probably also more potential for extended chronic use. As you know, MME is or morphine milligram equivalent is also indicate or looked at as a proxy for higher risk. And we found that in our data, the dosage for MME was mostly represented in that 21 to 50 MME bandwidth. Finally, we wanted to know what were some of the comorbidities that our patient population had. And focusing specifically on joint replacement and mental health, we found that the majority among those who had joint replacement were having knee replacement. And then with respect to the distribution of mental health disorders or alcohol dependence, we had quite a high number of patients across all of these, including alcohol dependence, schizophrenia, and depression. So when we looked at the data, this is just in summary. If you're working with us, we would have many tables and many weeks to be producing this. But in summary here, I'm presenting to you what we found what variables were found to be favoring the likelihood of an opioid use disorder. Here in the left-hand corner, upper-hand corner, we found that age increased the likelihood of an opioid use disorder. But for the likelihood of overdose, opioid use disorder was the main variable that would predict that. With respect to lowering the likelihood of an opioid use disorders, we found that gender had a role, so that women were less likely to show up in our data. So women who had been prescribed opioids were less likely to show up with an opioid use disorder. And people residing in the South also, granted that they had an OUD and that they had a prescription for opioids also, were less likely to show up in the data as having an overdose. You might also want to know how your data are generated. If there are any concerns about any stigma or any barriers to recording an overdose event or even an opioid use disorder event in your data, you might want to consider the results with that perspective. In the multivariate models that I'm showing you here a sample of the results, we found that specifically moderate to severe liver disease at the bottom here had a 4-fold odds ratio as related to OUD, and cerebrovascular disease also increased the likelihood of opioid use disorder 3-fold. How about mortality here? Very interestingly, in the adjusted models, we found that the presence of diabetes with complications increased the likelihood of an overdose after adjusting for all the other variables by 7-fold. And the same way, depression, the presence of depression, again, granted that people were prescribed an opioid and had all of these other variables controlled for, the presence of depression increased the likelihood of an overdose by 4-fold. Finally, just as a snapshot here, the overall overdose drivers, adjusted models here, where people resided made a difference. Prescription for benzodiazepine made a difference in increasing that likelihood of an overdose. Certainly a higher MME of opioids increased that risk, as well as mental health conditions. What decreased that likelihood was age, middle age, and interestingly, that deserves further exploration, consistently residing in the southern regions of the nation. Finally, we applied feature selection using machine learning models, and that feature selection was performed using support vector machine and random forest. random forest method was used to validate the feature selection, and the feature selection models developed were also cross-validated using the tenfold cross-validation. All the parameters in the model were ranked based on their impact score on the outcome of interest. With this, using AI and the feature selection, you see here that the top 5 parameters that were identified using support vector machine and random forest classifiers were more or less consistent, and save for some of the bottom here variables, hip replacement or alcohol dependence. I invite you again to be collaborating with us on your ideas for research related to drug exposure and outcomes for clinical outcomes. And here I would like to shift gears with our second case on population-based health, looking at variables that were more population-based. So we were very much really here motivated by what was happening around us and by the different words we were seeing, by the different graphs we were seeing in terms of the US case counts and rates here, as we have all seen it, distributed by region. Certainly the number of cases reported by day. You see here on the right-hand side that the cases, although decreasing incrementally, are not down to 0. And right now, certainly, we are facing a potential upsurge. We're not sure about the variants. However, our data or our question was, what are the variables that are driving or were driving the prevalence of COVID and the mortality of COVID? Our results might become timeless as we continue research on COVID and explore trends of vaccinations, trends of variants, and certainly trends of prevalence and mortality. We wanted to focus here in a multidisciplinary team on the different drivers considering the overall public health perspective. This was a pandemic that was not only evolving certainly in the clinical settings, but in the community settings. So we went back to what we knew or what the literature told us or still tells us about how much healthcare, so how much can we as healthcare researchers, providers, practitioners, etc., account for or be responsible for in the outcomes. And it turns out it's only the bottom part, 20%. It might be a sobering figure, but we've always known that health behaviors, physical environment, and other socioeconomic factors, now the latter account for 40% of the outcomes. So it was a natural question to ask for COVID, what were the relative contributions of all these strata that you see here? So we looked at different components, or if you will, domains of variables. And these are, for short, classified as health and healthcare, education, economic stability, neighborhood, and social and community context. Some of the data sources that you could consult are here on this slide, all the way from the Bureau of Labor Statistics to the US Census, going through the American Community Survey, and that's what we did. We were very interested in Maryland and in the surrounding states. The reason we confined this analysis only to surrounding states was to control for potential regional variations, which otherwise may not come up in our individual variables. So we looked at data from a repository that we use that pulls from all different types of data sources that I showed you, and that's Policy Map. Happy again to answer any questions about that or work with you on your research using that data repository. We used Poisson regression methods to adjust for the social determinants of health. And the outcomes that I'm going to show you are from data back to February. However, this is more important for the purpose of the presentation today to show you how we did it. Not necessarily the results, but mostly the methods and opening up collaborations opportunities. So we looked at prevalence, mortality, and we looked at these domains that I explained before. In short, what did we find? We found that high social vulnerability increased the prevalence of COVID by 21%. Unemployment, low education increased the prevalence. And the same was also observed on the right-hand side. You can see for mortality. Medicare coverage, interestingly, was productive. So what it shows us here is that if you live in a region where there's a higher proportion of the population around you covered by Medicare, the odds of COVID prevalence are lower, and certainly also the odds of mortality. So what increases here when we wanted to disseminate those results, we wanted to be sure that they were more user-friendly because we were sharing them with public health authorities. So we didn't want only to show numbers or graphs. Here, this is in a snapshot, shows you the impact of social vulnerability on prevalence and mortality. So social vulnerability, higher social vulnerability in a region or zip code increases the risk of increases prevalence by 21%, increases mortality by 26%. Again, as unemployment rises in an area, the prevalence of COVID is increased by 5% and the mortality of COVID is increased by 14%. Moving to the right here with lower rates of education in a given county as we define it as the proportion of the population that has less than 9th grade education increases the prevalence of COVID by 3% and doubles that risk for mortality. And the same thing, the same trend for opioid prescriptions. As I mentioned before here, what variables decrease the prevalence and the mortality of COVID are increasing rates of Medicare coverage and increased access to internet. And I mention these because some of these variables are actionable, as access to the internet. They may not change overnight, but it is important to consider them as we move forward. It's not only looking back and see what happened last year with the pandemic, it's moving forward because these same trends or these same variables that affected the prevalence and the mortality curves for COVID might be the same or not, but they might be the same that affect the curves for different variants or different conditions that we are looking at. We also looked at different clinical conditions in the regions that we observed for prevalence and mortality. And here of note is diabetes. That diabetes, even after controlling for COPD, age, gender, and race, increased the prevalence of, this is in Maryland, the prevalence of COVID and also the mortality of COVID. But interestingly, when we looked at the DMV, that's the Delaware, Maryland, and Virginia states, diabetes had a much higher impact. Perhaps because we had also higher numbers. So the observations allowed us for a more in-depth analysis. But here, if you look at this multi-state analysis, while diabetes increased the prevalence, which you will see in blue, of COVID, it increased mortality by many-fold and much more as compared to other components here. Some of them that we cannot change, age or other demographics, but there might be an opportunity for intervention here as we move forward and look at the emerging trends. This is to show you the impact of social vulnerability. And again, on the same web graph here, the impact of social vulnerability. And finally here, I will show you what the results of a multivariate analysis controlling for all the variables would look like. This is where, for example, the prevalence of COVID in the Delaware, Maryland, and Virginia area, the DMV area, was, I'll just pick one of the variables here, household size, was highly correlated with a higher prevalence of COVID in the DMV. And same thing, social vulnerability in the DMV area was highly correlated or predictive of COVID mortality. What's looking ahead here, I would like to tell you what we're doing in data. The Hopkins group is based on NIH-funded research, has developed with many different sites, ours included, participating in the National COVID Cohort Collaborative, the N3C. It is a partnership among the CTSA institutions to collect data on COVID and non-COVID patients, and it is a partnership between the Data to Health and NCATS. This is in a snapshot. It is all on the NIH website that you can refer to it, the accumulation of populations in that data. And finally, the dashboard, as of most recently, had accumulated all these data points. So with this, I would like to remind you or recap that we have presented a drug exposure study based on a commercial database. We have looked at a population-based study to look at outcomes from a current epidemic. We have also followed up with the current database that is being built on the national level to include data from clinical settings so that it is available for researchers. And finally, I will end with what we started with, that it is all about teamwork. And remember the analogy of the Olympics trickling down to the ICTR. We cannot do it alone. So I would like to thank you all for listening today and open it up to future collaborations and invite you certainly to reach out. Thank you very much. Goodbye.
I'm going to now turn over the session to Avery Johnson. And Avery, I'm going to just give you, are you able to share your screen?
It is allowing me now, yeah.
Great.
All right. So many thanks to those within the ICTR. We appreciate the collaborations and the support going through all of these projects. I did want to talk to you about real-world data resources that are available to UMB investigators, how the ICTR can support those projects, the data sets that are available within the Pharmaceutical Health Services Research, PHSR community database, and then core services that are available through PRC, which is our group. So I would like to review what the ICTR does support, what the databases are, and then who we are in general. The ICTR does support any of those who are assistant, associate, or professor faculty. It will support up to $5,000 in support, which does go a pretty long way in your projects. And projects, when you think about length and time, that are within a year's worth of work. I invite you to look at the application for more information, or always certainly send emails and we can follow up with what is available. The PHSR community database, this is a group within our department that has pooled databases together so that it is more cost effective for researchers to use through reuse, The databases that are currently available for research include about a 10-year span of a 5% random sample of Medicare beneficiaries, the enrollment, the claims, and the assessments. That encompasses about 2.6 million in the early years, all the way up to about 3 million in 2016. More recent data, the 2017 through the 19 data set, does include a 20% random sample, which is about 13 million persons in the most recent 2019. Again, that will include the enrollment, the claims, and the assessments, and those data are being refreshed annually as the data become available from the Chronic Condition Warehouse and CMS. So in December, we'll be able to request and get the 2020 data in-house. The geographies that are contained, this is always a question that we get, is zip code level within the Medicare population. So if you are looking at disparities, that is available all the way down to the zip code, which can then be linked to the census or other social measures that Dr. Shire were talking about to look at. We also have a newly refreshed 2006 to 2020 IQVIA 10% sample. This is the commercial administrative database that does have about 9.6 million beneficiaries within it. It does go down to the state level and includes enrollment as well as claims data. One of the smaller data sets that we do have is the 1999 to 2017 MCBS survey. This is where you will have enrollment, claims, and survey questions asking the beneficiary about their experience within the healthcare. It is surrounded by the Medicare population, so you will have a skewed sense of not only the over 65 population, but then those with disabilities. So if you want to use those data, you're more than welcome to, or you are also welcome to bring your data to us. We are a research group within PHSR. We've existed for about 20 years. Our vision and mission are to bring integrity, professionalism, and innovation to supporting those health service research projects that can be thought of and brought to life. Examples of research studies that we currently work through are drug exposure and health outcomes. We've looked at medication adherence, drug policy, disparities research, comparative and cost-effective analysis, and pharmacoecon types of projects. So that leads to the question, well, what can PRC do for me? If we think about a project life cycle, we'll think about initiation, planning, execution, monitoring, controlling, and closure. And what I'd like to bring to your attention is that PRC has the abilities to assist you with one or all portions of this project. So if we think about the initiation phase, that's the part of the project that is done before it is approved or funded. So it could include data exploration and feasibility. It could include proposal development. It could do literature reviews, methods and statistical analysis reviews. So we do have an economist, an epidemiologist, and pharmacist on staff. We do have PMP professionals, staff programmers, and a statistician. So if your project just needed proposal development assistance, we certainly could help with just that small portion, or we could start with the beginning of your project and work all the way through to the next phase, which would be the planning phase. So once your project is funded, you have project plans that need to be documented, you have project deliverables that need to be prepared, and you have your requirements that need to be outlined. We do have the ability to assist with and write your IRB and DUAs. We have a PRC secure server that's available to our clients that does meet all HIPAA requirements. We can assist with writing your statistical analysis plan, and we can assist with definition, implementation, and suggestions. Again, we do have the PMP professionals. We have project coordinators that can assist with the documentation. The statistician, the pharmacist, and epidemiologist certainly assist with statistical analysis plans. And with the PRC server comes a system administrator that would be able to help you on an IT level. When you're ready to execute your project, you may decide that now is the time you want to involve PRC, and that's certainly a possibility. We do have the ability to clean your data, create analytic files, complete the statistical analysis, visualize your data geospatially through timelines, through repeated events, and or just maintain the data on our server through a database management program. What goes hand in hand with that is monitoring and controlling. PRC prides itself on the quality control review of all programs. We do have multiple programmers working side by side who review each and every program, so there's at least 2 sets of eyes on each of the programs. We do create status reports, IRB continuing renewals. We do execute DUA extensions and prepare all documentation that you would need for support. When your project is finished, you have your deliverables that need to be confirmed, the finalization of documentation to tidy up those projects, and you may need data archived and or destroyed. We can assist with creating those final reports, the data management, the archiving, and or the destruction. So your question maybe is, why do you want to use PRC? Why do you want to consider the resources that we may have? When you think about your project expenses, you may need your PI to be supported financially. You may need a project manager, a programmer, a statistician, an analyst, IT support. You can quickly see that having 4, 5, 6, 7 different team members where you're having to support them wholly is going to be pretty expensive. We do also recognize that raw data and database management and servers are an expense, as well as any of the other miscellaneous expenses there. But when you think about PRC supported projects, you as the PI are not responsible for each and every one of those persons. You are still responsible financially for yourself, you're the PI, but then each of those other persons, you're coming to PRC to get a portion of. So maybe you only need 10% of a project manager as compared to the overall time, maybe 15% of a programmer, maybe only 5% of a statistician. So when you come to us, you can take those small chunks of all of the different people and create your team of itself. In summary, the ICTR funding is available to support your research projects. We do encourage you to apply for them. The PHSR community database data are available for reuse if the researcher doesn't have their own data set to use. The health services research professionals are available as resources across the life cycle of a project, no matter how small or large of a need it may be. And we are a budget-friendly alternative to staffing a full-time team. I would welcome you to reach out to our executive director, Dr. Abaria Nukwa. Her email is below. She is an economist within the School of Pharmacy and can certainly give you additional information and or reach out to me for further assistance. Thank you.
Okay, everyone, I think we can open up the session to our Q&A or our chat. Does anyone have any questions that they would like Avery to address? Okay, I've just added our link to the ICTR satisfaction survey. Please take a moment to complete that. Also, we will be putting the links to these presentations on the ICTR website if you would like We can also send that out via email to you, the link to those presentations. So if no one has any questions, okay. Thank you, everyone. I believe that we can end the session then.